Thank you so much for the opportunity to speak about cognitive behavioral therapy for children and adolescents with PANDAS. I really appreciate the invitation. I am currently directing our intensive cognitive behavioral therapy program within our overall child CBT program at MGH, and I hope to share a little bit about that with you as my talk progresses. So just to give you an overview of what I'm hoping to talk about today, there's been a lot said about some of the symptoms associated with the PANDAS presentation, and I am going to be focusing a lot of my talk about the OCD symptoms in particular, although I'm fully aware that there are many other anxiety symptoms or other behavioral issues that may arise that could be targeted using a CBT approach, such as separation anxiety, oppositional behavior, etc. I'm going to try to incorporate that into some of the information that I present. However, I am going to just go over some of the core symptoms associated with OCD regardless of etiology, discuss our cognitive and behavioral model of OCD. I would like to give you a crash course in what should be happening in CBT for these children, what's supposed to be most effective, and review the studies that support its efficacy. And then I'm going to spend some time talking about how CBT could be modified for youth with the Panda subtype. I'm going to provide a hypothetical case example and then talk a little bit about how to find CBT therapists for your children who would be familiar with PANDAS. So many of you are familiar with the types of obsessions and compulsions that are common among children with OCD. Just to give you a sense, many of the common obsessions that come up are contamination or illness concerns, fear of harm to self or others, and that's not to say that they're suicidal necessarily, but just concerned that maybe they could do something to hurt themselves or others. A lot of concerns about what's right or wrong, or what's moral or immoral. I've had some kids who just fear, say, going into a store and thinking, what if I steal something, or what if I did somehow steal something, or what if I cheated on a test? Superstitious sorts of obsessions. Things that I commonly see are, I can't wear that shirt. I threw up the last time I was wearing that shirt, so that shirt now has to go in the drawer forever. So that's a superstitious obsession. And also intrusive sexual thoughts, especially in adolescence. And then common compulsions that are associated with these obsessions, obviously excessive or ritualized hand washing, cleaning, checking, touching, counting, ordering or arranging things, and perhaps the most ubiquitous, I think, confessing or reassurance seeking, especially from parents. So asking the same question over and over again, are you sure I'm okay? Are you sure? Happens a lot. I put this model as part of the slides I'm presenting just to give you a sense of how cognitive behavioral therapists conceptualize pediatric OCD. And I tried to use a Panda subtype as an illustrative example. The squares in the top corner, those are the proximal and distal triggers for the onset of OCD. And what I mean by that are, in terms of distal triggers, things that make kids more vulnerable to developing OCD symptoms. So that might include genetic history, so family factors, things like temperament. I often hear in treating kids presenting with PANDAS that these kids may have had some pre-existing anxiety or have tended to be more shy throughout their life, despite the fact that things have gotten much, much worse since the PANDAS onset. But also you have the more proximal trigger of the disorder, so as has been discussed today, for example, strep infection. But then we'd like to break it down into different pieces that may be maintaining the disorder despite whatever it is that's triggering or causing it. And the way that we break that down is by talking about the thoughts that may arise, the cognition, so to speak. For example, the intrusive thoughts I was just discussing, the perseveration, so getting stuck. We often talk about sticky brain, just not being able to get your mind off of a particular issue or thought. The physiological symptoms, so many of these children have a lot of physical discomfort that is associated with their anxiety, so heart racing, sweating, panic type symptoms. And then, of course, the associated affective reactions, acute anxiety, frustration, anger. And then the behavioral responses, things like compulsions, often rampant avoidance. So kids who were fine with going to school no longer feel comfortable there. They feel in such a state of panic and are so perseverative that they just can't concentrate, can't focus. And then for children who are really experiencing some of the cognitive deficits associated with PANDAS, so poorer school performance, just aren't feeling good about going to school any longer. And these factors all sort of play off of one another to maintain the disorder. So obviously, if you're having cognitions that are very anxiety-provoking, you're not going to be as likely to face different situations that you think are associated with those thoughts. So you're not going to want to, for example, go to public restrooms if you're having a lot of contamination concerns. But because you're not going to the restroom because of your contamination concerns, it sort of reinforces your ultimate belief that that's going to make you sick. So the very avoidance is preventing you from testing out any hypothesis that you might have. I'll talk about that in a minute. So that cycle that sort of maintains the disorder then leads to environmental consequences that then feed back. So I talked about missed school, but also other ways that development can be interrupted include peer relationships, so not wanting to spend time with friends any longer and starting to lose those relationships and becoming increasingly isolated can bring on feelings of depression or thoughts of depression, poor self-esteem, etc. So that's how we'd like to think about the disorder. And just to go into a little more detail, there are other vulnerability factors that put kids at greater risk for developing symptoms of OCD. Again, regardless of etiology. There's certain type of thinking styles associated with OCD. I'll review a few of them. Kids with OCD tend to really overestimate the risk of something bad happening and take on a lot of responsibility. I can think of an example of a kid feeling like she had to really protect all of her loved ones from cancer through various compulsions because she really felt like if she didn't do it, who would? There's also intolerance of uncertainty and self-doubt, so just not being able to not know for sure of something, and if there's even just a small chance that something bad could happen, they still feel like they need to engage in the compulsion. And finally, thought-action fusion, the idea that bad thoughts are the same as engaging in bad actions. So for example, if a thought comes into my head that I want to hurt someone, it's just as bad as actually harming someone. And the resulting guilt that you may feel as a result of that and feeling like you need to neutralize it in some way by doing something good or engaging in a particular compulsion. I also just want to very briefly talk about the classical conditioning processes that are associated with the maintenance of OCD. So, if we use a classic example of a child who's fearful of becoming contaminated with germs, if they encounter something that they believe is germy, like riding on the subway, for example, their anxiety might spike to a high level. And so what makes them feel better in the moment is to engage in a compulsion of sort. If they're on the train, maybe using hand sanitizer brings their anxiety right down. Makes a lot of sense to do that if it makes you feel better, right? Problem is, it only works for the short term. The next time you encounter that same situation, your anxiety spikes right back up, and you feel like you have to keep using the hand sanitizer in order to achieve that relief. And that's a process called negative reinforcement, removal of something aversive. The problem with this is that it doesn't actually solve the problem ever, so that over time, you're still feeling very frightened of these different types of situations, and it may generalize to other things. And as we're going to talk about with exposure therapy, the idea is to break that cycle down in a way that's in the short term much more uncomfortable, but in the long term actually going to solve your problem of feeling anxious about the particular situation. There are also family factors that may go into the cognitive behavioral cycle of maintaining OCD symptoms, family accommodation in particular. Parents who are very well-meaning and wanting very much to help their children feel less distressed, understandably, may do things like engage in children's compulsions or rituals, or they might provide excessive reassurance thinking that that's going to help the child feel better, which it does, again, for the moment, but then it might become a vicious cycle over time where it's hard to break that pattern. And so family members may inadvertently facilitate avoidance of feared stimuli, thinking that they're protecting. And in some extreme cases, families may completely modify their lifestyles to accommodate children's OCD. So, for example, I can think of families who've prepared separate meals so that a child feels comfortable with the food that's being presented as not being contaminated, things like that. So I won't go into a ton of detail about the way that we assess OCD symptoms. We have a number of tools available to us, including structured clinical interviews, has been mentioned already several times today. The CY box is sort of the gold standard for assessment of obsessive compulsive symptoms in children. And there are some other self-report, parent report types of measures that can be useful in tracking improvements over time, as well as severity at baseline. So I'm going to review some of the CBT treatment components that are most effective in helping kids with anxiety symptoms and OCD in particular. It's a crash course, really, but I think that this information can be really helpful in helping you become a consumer of CBT, knowing when you're selecting a therapist that they're doing the sort of treatment that could be most helpful for your child. So first and foremost, before you can do any sort of exposure and response prevention therapy, you need to help the child understand what's going on. They need to buy into the idea that this is something that could be helpful for them. So just in the way that I outlined for you the cycle of OCD from a cognitive behavioral framework, I do that same thing for the kids and adolescents that I'm working with. And obviously the developmental level of the child will dictate in what depth or detail I go into that model. So it's really helpful just to kind of map out the child's symptoms over time and draw connections to particular triggers, which may include strep infections, but also other stressors, and to have a plan in place for what to do when those triggers occur. So it might include getting booster sessions from your CBT therapist in the future. It may mean eliminating certain types of stressors for the time being until the child can become well. It definitely depends on the particular individual. We also encourage children to externalize the OCD symptoms as it's not them, it's something else that we're sort of fighting against. And also to just help them understand that people can have random, scary thoughts that pop into their head without them having to mean anything in particular. Sometimes the difference between someone with OCD and without is that somebody with OCD questions the meaning or the interpretation of the thoughts that they're having, whereas other people might be like, oh, that was weird. Okay, move on. And then, of course, for the child, when you're initiating treatment, is to give them a really good sense of why we're asking them to face situations that are anxiety-provoking. Like, why would we ask you to do something that's hard? Clearly not to torture you, I promise. Instead, it's to get you to a place where you can feel better and better and more confident in situations that are going to keep coming up for you over time. We often do brief cognitive training for kids presenting with OCD symptoms. I say brief in part because we know the meat of this treatment is in the exposure and response prevention, but we want to give a toolbox, so to speak, of skills for kids to be able to use when they're engaging in exposure response prevention. So I personally will teach kids to conceptualize their intrusive thoughts or obsessions as spam messages or junk mail. It's the idea that, your brain's kind of sending you a lot of different messages throughout the day, and you get to choose which you pay attention to. If you're paying attention to the intrusive thoughts that are more like junk mail messages, it really takes a lot of your time and a lot of your energy and takes away from things that are going to be more important to you, like playing video games or hanging out with your friends. So the idea here is to really understand that we're going to get a lot of junk mail that's better to just kind of toss and not pay attention to. In fact, some kids with OCD that I work with, I won't even get into the logic around, well, that can't be true for the following reasons, because it's often a waste of time. I almost prefer the approach of saying, that thought's it's not deserving of our time and attention and logic right now. Let's set it aside, like we would put a spam message in a filter folder. Encouraging kids to have basic self-statements that they can use, like, that's just my OCD talking, or I don't need to pay attention to that. And in some cases, I will do some of that more formal, what we call cognitive restructuring, where we have kids evaluate the evidence for and against their thoughts and generate alternative explanations. And typically that's in situations where they're way overestimating the likelihood of something bad happening. And then, like I said, the meat of this treatment is the exposure and response prevention therapy. And I just wanted to break this down into some basic examples to share with you so that you can have a sense of what this might look like practically. So the first thing that you want to do is develop what we call a fear and avoidance hierarchy. So this is a list of situations of different types of situations associated with a particular fear that we then get a sense from the child of how anxiety-provoking each of those steps would be. And then we proceed with the item that would be mildly to moderately anxiety-provoking, and then work our way up to the item that would be most difficult. So with this approach, we're not forcing kids to jump into the deep end of the pool right off the bat. First of all, that would make them completely disengaged from treatment. And secondly, it won't give them that sense of self-efficacy that we're hoping to build over the course of treatment. So beginning with something that is in the more mild to moderate range, hopefully we'll give them a model of what it's like to face their fears, see that they can tolerate it without anything bad happening, and then hopefully create that momentum that's going to make them more successful overall. So I give two examples. The first one is a contamination-related example, thinking of a kid who just felt so fearful of germs that he was avoiding being in the kitchen. So the first item might be allowing his mom to touch something in the kitchen, like the kitchen sink, and then touch his arm, and then give it a little bit of time before engaging in the compulsion. So we're not taking the compulsion completely away, but we are delaying it, which is a strategy that can be helpful in getting kids to the point where they can eliminate it. And so you can see that it progresses from there and gets up to the child actually touching the kitchen sink with a delay, and then touching the kitchen sink without washing hands at all would be the ultimate goal. And you can see very anxiety-provoking for this particular child. That's the other thing I should mention is initial anxiety ratings for one of these items on the hierarchy, that can change over the course of treatment. So usually by the time the child is at that point in the hierarchy, they're no longer rating it a 9.5, for example. With success on the earlier steps, oftentimes by the time they get to the hardest one, it's like, okay, that's still quite hard, but it's not as scary as I thought it would probably be. And here's just another example. This is a hierarchy that we might use for a kid who feels compelled to confess everything they thought they did wrong during the day. So again, using delays, like waiting 5 minutes before confessing to the parent, is a step that is often doable for kids. And then 30 minutes, making the confession but not getting that response from the parent. And working our way up to the most of just not making a confession at all for something that the child thinks is a serious offense. So I talked a lot about starting with the least anxiety-provoking item on the list. In session, so with your cognitive behavioral therapist, you're going to do as many of these types of exposures as you can. And if you can do it in the home or in the community setting, even better. The therapist is really guiding the process and getting a sense of what's happening to the child's anxiety level over time. And often what you see is an initial spike in anxiety as you're beginning the process, but hopefully habituation in anxiety over time to some extent. There are ways if a child is just not ready at all to do any of the items on his or her fear and avoidance hierarchy, we do use what's called imaginal exposure, so having kids imagine being in a particular situation as a step towards actual exposure. But regardless of the type of exposure, we try to remain in the situation until anxiety drops somewhat. We don't have to have the anxiety go down to 0 in order for it to be effective. In fact, in my experience, that doesn't happen too often. But just for the child to see that, wow, I'm having this anxiety, I'm tolerating it, it is going down somewhat, I'm feeling a bit better. That is such an important message and can really help kids gain some confidence in being able to approach these types of situations. And of course, practice makes perfect, especially in typical once-a-week outpatient therapy. You can only accomplish so much within that period of time. It's what happens in between those sessions that matters the most. So being able to practice agreed upon exposures between sessions really makes the process go much more quickly, and it solidifies the learning. I'll talk about reward plans a little bit more in a little bit in terms of motivation, but it's something that is used especially for younger children. And then finally, lots of parent guidance, being able to help parents know how best to support their children as they're engaging in exposure response prevention therapy, striking that nice balance of being validating and supportive without giving too much reassurance in a way that feeds into the OCD cycle. It's a hard thing to get right. It's a process over time. Many of you may be familiar with this literature, but I wanted to give you a sense of how effective CBT can be for OCD symptoms before I get into some of the PANDAS-specific literature. The largest randomized controlled trial to date, the POT study, showed that children with OCD do benefit from both sertraline or Zoloft and CBT. So they divided a group of kids into 4 different treatment groups, CBT only, Zoloft only, the combined treatment, and medication placebo. They gave the kids 12 weeks of treatment plus 4 extra for kids who responded. And what they found was, if you just look at reductions in OCD symptoms, children who received the combination treatment, so CBT plus Zoloft, did the best, followed by the monotherapies, or CBT, Zoloft alone, and then placebo having the least response. If you look at the rates of clinical remission, so kids who remitted from the OCD, they found that the rates were highest for those kids who received CBT, either in combination with Zoloft or alone. And there have been a number of other studies that have also supported the use of CBT for OCD symptoms. Some have been more family-based treatments. So Barrett and colleagues looked at cognitive behavioral family therapy, both in a group and individual format, and found that either format produced significant improvements in their kids. And John Piacentini and his colleagues also looked at a family-focused CBT, sort of took out the exposure piece of it and found that the CBT group showed great reductions in OCD symptoms and greater decreases in impairment and family accommodation compared to that control group. I want to talk a little bit about intensive CBT. Intensive CBT contains all those same treatment components, but the treatment is delivered in a much shorter period of time, usually over the course of 1 to 3 weeks, with frequent longer sessions. That kind of treatment has been shown to be as effective as weekly CBT, but the good part about it is that it may lead to more rapid improvement, and more rapid improvement hopefully will lead to less developmental disruption. It may also be a springboard for more typical weekly outpatient CBT to maintain the gains that have been made in that short period of time. Eric Storch and colleagues not too long ago looked to see how well kids fared with intensive CBT, looking at 40 kids with OCD, randomized to either 14 sessions of weekly therapy or daily family-based CBT. And they found that if you look just immediately after treatment, the intensive group fared better in terms of being less ill, having higher rates of remission, greater percentage being considered responders. And then those outcomes became equivalent at the 3-month follow-up. So it may be that kids who get the weekly format just need a little bit more time to practice the skills and exposures to reach that same level of improvement. There is quite a paucity of research on CBT for kids with PANDAS subtype OCD. In my review of the literature, I've found one study, also conducted by Eric Storch and his colleagues, and it was not a randomized control trial, but rather a waitlist control trial of a small group of kids. There were 7 kids, all of whom were between the ages of 9 and 13 and diagnosed with the Panda subtype of OCD. So specifically, all of them had a group-based strep infection preceding sudden onset or acute exacerbation of OCD symptoms. All had abnormal neurological presentations of some sort or another, including frequent urination, decreased school performance, handwriting deterioration. And most, 6 out of 7, were already taking an SSRI medication by the time they completed this trial, and those medications remained stable during the CBT. So the way that they assessed improvement was they assessed the kids at baseline, they waited 4 weeks, and then they assessed the kids again, and they found that there was really no difference over the course of those 4 weeks in terms of symptom presentation. Then they started the intensive CBT program, which consisted of 14 90-minute sessions over the course of 3 weeks, Then they did a post-treatment assessment and a 3-month follow-up to see how well they did. And what they found was at post-treatment, those kids, compared to where they were at before they started the treatment, they had 68% reduction in their OCD symptoms. A clinician who assessed the children but didn't know what kind of treatment they were receiving or if they had received any treatment, 86% were rated as treatment responders. 79% no longer met diagnostic criteria for OCD. Looks pretty good. At 3-month follow-up, they found that some of those gains had not been maintained, but many had. So 46% reduction remained in the OCD symptoms, 50% were still considered treatment responders, and 50% still were no longer considered meeting criteria for OCD. But an important point to consider is that 3 children did experience a partial or full relapse by follow-up, though the symptoms remain less severe. So I think the take-home message here from this very small study is that despite the episodic nature of PANDAS, CBT may have a preventative effect by teaching parents and kids strategies that they can use that mitigate the severity of symptoms when they arise. So this is part of like an ongoing treatment plan rather than a fix-all in the moment. So given the lack of research that has been done on CBT, Panda subtype of OCD, we're sort of being guided by anecdotal information that helps us understand how best to treat these kids. And so I'm going to share with you the anecdotal information that myself and my colleagues in our CBT program at MGH have gathered over time. I'm happy to talk about this in more detail at the question and answer period as well, because I think there are a lot of different considerations depending on what is coming your way. So one important piece is I found it to be much more helpful to wait until a child is experiencing more residual symptoms of anxiety or OCD before embarking upon CBT. What I mean by that is CBT is probably not going to be so helpful if you have a kid in so much acute distress that they're not going to that they're not able to function at a level that would help them be able to learn the skills that are necessary for this to be an effective treatment. So if they're experiencing so much distress and tears, are not cognitively able to grasp the concept that you're trying to teach them, that's probably not a good time to initiate CBT. So I usually say. It's not a magic wand. Do not embark upon CBT at the height of symptom exacerbation. Wait until symptoms are less severe or residual. However, you don't want there to be no symptoms at all. It can't be preventative in that way without being able to have some things to work on, because remember, the most important part of exposure response prevention treatment is to help kids tolerate distress and see that they can be in a fear-provoking situation without engaging in compulsions or safety behaviors. So it's kind of a tricky balance to get. You want kids to have some symptoms to work on, but not so sick that they can't actually grasp the concepts that are being taught. Very much use a treatment team approach. This goes for a wide range of disorders, but particularly for kids presenting with a Panda subtype, we want to make sure that we're communicating frequently with the psychiatrist and immunologist, if there is one on the team, the pediatrician, who's involved in the child's care, and any other providers. The school, I should have included that there as well. Oftentimes schools have no idea what's going on and need as much information and support as possible to help kids re-engage in the curriculum and even in attending school. So I'm often on the phone with school counselors, even teachers, how best to support kids and to really share information, because the teachers obviously get to see the kids over long periods of time during the day and can tell you what they're observing and what you might need to be working on as part of your treatment. What I have found in treating kids who have anxiety as a result of PANDAS is that we often need to include additional skills, the coping skills that are going to be so important for kids to have in dealing with this illness. And there are many to be taught, just given the intense levels of distress. So emotion regulation skills that we might teach in our program include relaxation strategies or imagery training, things like mindfulness, and acceptance skills. So being able to say, like, yes, I'm having this thought, I'm having this feeling, and it's okay. It doesn't have to be something terrible, or it doesn't have to be a sign that I can't handle things. It's just a thought. It's just an image. A lot of distress tolerance, so finding ways of reducing the intensity of the emotion dysregulation that can occur, and having that plan kind of rehearsed and in place for when infection may reoccur. So things like distraction, self-soothing, listing favorite activities, things that they know will just make them feel better as things come up. And finally, behavioral modification charts, or systems that can be administered by parents for oppositional behavior is very helpful. So I mentioned reward plans before, and so I'm thinking of two different approaches. One reward plan would be tied specifically to the exposure and response prevention, so kids kind of earning points or stickers if they're younger that they can then turn into or cash into a particular prize. And it doesn't have to be anything lavish, just even special treats and family outings and things like that can be a nice motivator for kids to participate in, a way to celebrate the progress that they've made. There can also be a place for using those sorts of behavioral systems to deal with some of the oppositional behavior at home. That's kind of a whole nother talk about how to approach all of those different types of symptoms that can come up, or behaviors, but oftentimes helping families kind of agree upon particular goals for the child. So for example, going a full day without hitting their brother. And then a second piece might be going a full day without using swear words towards their parents. Those are the kinds of real goals that I set with families, and kind of discuss ways that they can get rewarded for that each day through consistent reward systems, in the same way that we might reward kids for participating in CBT. And I can talk about that in more detail if people would like a break. And then finally, what I have found to be really useful, and maybe this is across diagnostic categories, but booster sessions I have found to be particularly important for kids with PANDAS, just given the risk of relapse. So meeting regularly after the end of treatment, so monthly or every other month, just to kind of take stock, reinforce the skills that they've learned, and making sure that they're continuing to use those skills at home on an everyday basis. I find that can really be a good part of the overall treatment trajectory. So the case example I'm going to present to you, it's not a real case, obviously, given confidentiality. I can't describe a full case, but this is sort of a typical kind of picture that we see and how we might address some of the symptoms that are presenting. So Paul, 13 years old, several years ago, prior to initiation of CBT, had a very rapid onset of OCD symptoms, especially characterized by obsessive concern about contamination. In particular, he was worried about anything that could lead to illness or disease. So it could be things like insects, worried about ticks, germs, expired food. And that resulted in compulsive hand washing, checking, and avoidance of many different foods. What made him a little bit sort of different from a typical OCD presentation is that he also had very explosive reactions to triggers of contamination fear. So it wasn't just feeling scared, it was being almost rageful, horribly frustrated when experiencing something that made him fearful of contamination. And those episodes of frustration could last for hours. And he also had a deterioration in school performance. Had a confirmed strep infection, so we knew that this was a Panda subtype. So before treatment initiation of any sort, not even just CBT, he had a very high CY box score. This is what we often see, often in the severe range. And what we often see as well is that a trial of something like Augmentin may lead to significant improvement, more in the moderate range. But despite that effective treatment, there may still be waxing and waning symptoms over time. And I will often see then kids getting a trial of an SSRI medication, in Paul's case, Zoloft. Paul's psychiatrist recommended CBT to address residual symptoms of OCD, And then a pretty typical course of treatment in an outpatient setting would be 14 sessions, including some of the pieces I mentioned before, like understanding the relationship between thoughts, feelings, and behaviors, and how compulsions can reinforce those beliefs, helping him generate what we call boss-back thoughts to counter those obsessions about germs. An exposure plan that may begin with starting to touch contaminated surfaces and ending with eating foods that are just past their expiration date, not checking the body for signs of insect bites. I know it seems a little odd to have someone eat something that's a day past expiration, and I often say, like, we often go a step beyond what you might normally do in everyday life, because if you can do that, then you can really handle the stuff that's going to come at you every day. So I know people kind of have this stereotype of CBT therapists going around and touching toilets with their patients. It's true, we do that, but it's so that people can then go to the toilet without touching it, without so much anxiety or fear. So we're not trying to create any food poisoning, but usually one day past, you're going to be all right. And then for Paul, or kids like Paul, we might often teach self-monitoring of frustration levels. So, okay, Paul, 0 to 10, where are you at? How angry or frustrated are you feeling? And if you're getting above a 6, what might you do to help bring your frustration level further down that scale? So for him, that might be trying to do something that's relaxing or distracting. But really the goal there is for kids to be really good at catching themselves before it becomes a much bigger, more explosive episode. And then what we often see is that booster sessions are helpful in maintaining those goals. I wanted to provide you with some ideas about how to find CBT for your children, and CBT that's going to be effective. I have heard a number of people approach me in various capacities and saying that, well, we found a therapist and they said they did some CBT, but they were just doing relaxation, and that's really not helping my child. Relaxation can be a useful skill, but it's certainly not the most effective treatment component, especially for OCD symptoms. So I prepared a list of programs that we know deliver excellent CBT, and I started with the intensive CBT programs. My program in particular at MGH provides 2 to 8 days of treatment, 3 hours individual each day. I provided the link there. There's also a program down here in Providence at Bradley Hospital that's a combination of individual and group CBT. It's approximately 3 weeks, 3 hours a day, 5 days a week, so it's very intensive. And I believe that parts of that are also insurance covered, which is a boon. There is a brand new program at McLean that my understanding is they're about to open their doors in a few weeks. Kind of a similar model, only perhaps for a longer period of time, of intensive group CBT, lots of exposure-based treatment, medication consultation. So those are some programs to check out. If you're looking more for weekly outpatient CBT for people who are likely to have familiarity with PANDAS and PANS, I mentioned the International OCD Foundation referral list because there's a lot of good providers there. Our overall program at MGH, it's specific to people who have some sort of MGH connection, so a specialist or a psychiatrist or have been evaluated there, but it is also a resource, and that's an insurance-based program. At BU, there's the Center for Anxiety and Related Disorders. Here, there's the Pediatric Anxiety Research Clinic at Bradley Hospital. In Connecticut, there's the Institute of Living at Hartford Hospital. And finally, in Boston, there's the Judge Baker Children's Center. They have a group that specializes in CBT for kids. So those are good places to start at the very least, and even if you can't be seen at those particular settings, oftentimes there's staff to help you be able to identify other folks who are excellent CBT therapists. I thank you so much for your time.